All right, let's do this. Welcome everyone to this week's Journal Club. If you are new to the Journal Club or the Clinical Athlete Community in general, welcome. You can take part in this meeting in a number of ways. If you want to join the conversation and either unmute yourself, show your face, or do both, you can just type the word question in the chat and we'll ask you to unmute yourself and you just join in the conversation. You can also, if you don't want to do that, but you do want to have your comment or question discussed, you can just type it in the chat and we'll read it off and talk about it. And if you just want to be an active listener and soak up the conversation, you can always do that as well. We'll do breakout rooms a little later so that you can get your discussion on. And these meetings are open to anyone as always. So if you have friends or colleagues that ever want to join in, you can share with them the link. We do them every week. And we do record them, and you'll get sent the recording in the next couple of days, and then you'll have access to that for 7 days. And after that, the recordings go into the Clinical Athlete Forum, which I'm going to put a forum application here in the link. And we're going to do a big forum cohort here in the next week or so. So if you have applied in the last couple of weeks, be watching your emails. And if you want to apply for this coming month, do it now so you can get your application in. That's in the chat below. And I'm going to put the papers in the chat as well. So just in case you didn't get a chance to download them, these links will take you straight to the full PDFs of the 2 papers that we're going to talk about today. And just a real quick note on sound. If you were unmuted previously to join the conversation and then later you're not speaking, try to mute yourself so that your background noise doesn't come in. Otherwise, use the chat as live discussion. You can have kind of your side discussions going. People drop in references and resources in the chat, and it's been super useful so feel free to use the chat how you see fit to interact with each other. With all of that said, welcome to Clinical Athlete Journal Club number 32. My name is Quinn Hennick, and I am a proud clinical athlete provider. And fingers crossed, tonight I'm joined by Kevin McNamara, who is a physical therapist in the Seattle area, and he's a longtime Clinical Athlete Forum member and the one responsible for bringing this journal club to life. Kevin, is your audio working this week?
I believe it is.
Oh,
tell me if I'm wrong.
I missed you. I missed you so much.
That's what I get for trying to do these on the road, but back at the home base now, all good.
It's good to see you, man. Next time we figured it out. Neither myself, Kevin, or Megan thought about just using your phone next time, just like use mobile, but we're back. It's all good. Speaking of Megan, shout out to our Clinical Athlete Journal Club intern, Megan Broussard, who's a student PT down in Texas at UT Southwestern. Say hi to the people, Megan.
Hey, guys.
And Megan's going to help curate the questions, and she's a huge help at these meetings. So very last thing, you've heard it a million times, but it doesn't hurt to hear it again. We started these meetings with a motto that we have taken from Benjamin Franklin and his weekly Junto club that he had back in the day, which was a mutual improvement club, where they got a bunch of really smart people to discuss topics and ideas of the day. And they had a motto, and it was that their meetings were conducted in the sincere spirit of inquiry after truth, without fondness of dispute or desire of victory. And we have adopted that motto here at the Clinical Athlete Journal Club. So we're all on the same team. We encourage healthy discussion, but we're all just trying to be less wrong here. So tonight's Journal Club topic is overuse injuries. And we've got 2 papers, but I'm going to launch our Who Are You poll first, just to get a feel for the room. So if you see that pop up in front of your face, let us know. Are you a coach, clinician, student coach, or trainer? Looks like so far we've got about close to 50% clinician, I'm just watching the numbers while you guys awkwardly watch me watch the numbers. Here we go. Okay. I'll just share the numbers. There we go. So a lot of clinicians in the house. Got couple coaches. When student coach, hey, it's all relevant, right? We're all just kind of surfing the performance rehab curve. So good. Where do we start with these papers? So we'll start with the first one, which is the shorter one, which was titled Training Load Error is not a more accurate term than overuse injury. And I wasn't familiar with the lead author on these two papers, but I'm going to assume that he is potentially a PhD student of either Aaron Coots or Franco and Pellizzeri. And Franco has been on the Clinical Athlete podcast. You can Google that. And we also discussed a couple Franco and Aaron Coots papers about training load some meetings back, specifically the acute to chronic workload ratio. So he's a familiar name. But it's, this first one was a one pager, and they made a compelling argument essentially saying that over the last 5 years or so, with the boom in training load research and just kind of research on quantifying training load, trying to link it to injury risk, there's been this idea that potentially we should shift these kind of insidious or what would typically be termed overuse, to say bone stress injuries, tendinopathies, idiopathic joint sensitivities. Instead of overuse, we call them training load errors. And this paper makes a case that, well, that doesn't actually help us. It doesn't get us any closer to intervention. It doesn't get us any closer to risk reduction strategies. And it actually is too reductionist, because training load is one of many, many factors that can have an effect on these injuries and can have an effect on the stress and strain of the tissues in question. And they made a decently compelling argument. I don't know if, ultimately it was their suggestion for continuing the definition was injury caused by overuse. So I don't know if we got anywhere with that. And we can talk about, overuse maybe still being potentially as reductionist as training load error. But I did understand the case that was made here. Kevin, what do you think about that first paper?
Yeah, I share similar thoughts. I think kind of reflecting back, even just thinking about like the term overuse injury and kind of training load error, it does seem, overly reductionist, kind of like you mentioned. If you just think about it like at its face, right? Because when you think about tissues involved for something like a bone stress injury versus something like a tendinopathy, or even something like, as nebulous as patellofemoral pain or anterior knee pain, like they're kind of very different, right? Just in regards to like the tissues involved. So it does make sense to me to suggest, like as they did in sort of the second paper, as far as trying to tease out some of the differences in through there. Looking back on it now, the idea that there would be a consideration to shift towards something as simple as just an overuse injury being a training load error, it does seem very kind of short-sighted and seems like it does miss a lot. So especially kind of looking at the second paper, first of all, hats off to them, because I think they did a really good job at trying to take something as complex as something like an overuse injury and trying to make it somewhat more digestible and provide a framework to how rehabilitation professionals can kind of utilize their skill sets to kind of intervene at the locomotor or the neuromuscular system to try to influence physiology in a positive way. I think the directions that they are making and the steps that they're taking in that second paper are really great. I don't know how much closer it gets us in terms of being able to really kind of pinpoint or determine where we need to go or how exact we need to be with some of our interventions, but it definitely seems like it's a much better step in the right direction in terms of trying to understand, why certain tissues get injured or are prone to certain injuries. So I think the model that they proposed seems much more holistic and all-encompassing than something like a training load error type of definition.
And everybody, again, feel free to, if you've got thoughts, put them in the chat if you want to join the convo, either audio or video. Just type the word question. What do you think about the term overuse? Just to kind of be pedantic about that for just, a second, and before we move on to the actual model.
I mean, I don't have a better one, so I guess until then, I think it probably fits fine. I think there's more kind of nuance to something like overuse as opposed to just training load, because if you do look at some of the ways that some of the different tissues respond and things like that, especially as they start to talk about stress related versus strain related, I think that there's probably a little bit more. It's a better umbrella, I would say, as opposed to just training load overuse, because I feel like it allows for a little bit more investigation into certain specific tissues and things like that. So I guess at this time, if I was being asked, I'd say I would be preferential towards overuse versus training load.
And it's potentially a conversation about who we're talking to. And, I don't remember the last time that I told somebody that I think that you have an overuse injury. I don't know if I can't remember the last time I actually used that term, but I explain things in a way that is hinting towards that a lot of us will say too much too soon, or too much too soon after doing too little for too long, to quote Scott Morrison. But to me, that's synonymous with training load error. We're honing in on the too much doing, and that it was too much. So I think we kind of run into the same problems when we try to actually explain these to patients. But if we can just take, especially the second paper, which is essentially trying to model these types of injuries for research and for creating causal inference, from research to clinician, we need some type of language to be able to discuss these things, and to call something, excessive stress strain beyond tissue strength injuries. How much words do we want to put in this thing versus just kind of overuse injuries, where we can bucket a lot of different things across different populations, and then spawn the conversation off from there. So I agree with you that there's not an easy answer on it, but I don't have a better alternative. Chris, you're on. You didn't type the word question, but that's okay.
But we're gonna give you a pass.
Yeah.
So I know Judd. I've actually talked to him about some of this stuff, and he being with Franco, and if you guys have read anything from Franco, and I'm sure that if you know Tim Gabbett, then you probably know Franco for a lot of reasons. But ultimately, in asking Judd about some of this, their big initiative, and his big initiative with his PhD, is to start to speak more practically and more matter of fact about these issues, as in, Kevin, like you were saying, like to start to include these studies that are real, for lack of a better word to put that, but that include some of the nuances. And in asking him about this, he's like, the reason that we want to get away from that is because it's not just a training issue. It could be any load issue. It could have been an unintentional stressor that's not a training effect, but just like you trained in the morning and then went for a long walk in the afternoon. It's still a mismatch in tolerance versus input. However, it better satisfies, and that's ultimately what he and his group are trying to get into, from what I understand, is like, even with their knee biomechanics, they recognize that there are biomechanics associated with knee pathology that aren't good. However, we need to put that in the context of the individual and not just say knee valgus is bad, but that you're leaving out the fact that, well, sometimes knee valgus gets you from point A to point B faster than it, faster than it wouldn't. And so they get into this performance injury paradox. And I think that's where some of this was coming from. And I told him we were going to review his paper, and he said, "Don't worry, I'm sure they will realize I'm a clown after reading my papers." So,
well, maybe we have to get him on the podcast so the world can know that he's a clown. And I say the world, we have 6 listeners, so I'll get off my horse now.
Yeah,
Chris and Kevin and everybody, our student forum intern, Christopher Hewman, just threw an interesting question into the chat. And he says, can we just call it an injury? So why the qualifier of overuse? What are your all's thoughts, or anybody else's thoughts on that as well?
I agree, right? Because I think in many ways, maybe I'm wrong, but my kind of like initial sort of thought process when you hear anything like training load injury or even overuse is it's very sort of I guess almost leads to like a presentation of being very volume centric, where that may not be the case, right? If we just think about like an injury, like it could just be a single magnitude load or something like that, right? So I think the way that they presented it in terms of being like overuse versus training load, I think it does seem to have, at least the way that I think it comes off initially, is being purely like a volume issue, right? And that may not necessarily be the case. It could be an indication where, kind of like they talked about in the second paper, where maybe you're not influencing the physiology or creating the adaptations necessary because there's not enough higher magnitude, lower volume exposures or something in the training block. So I think there's probably room to kind of parcel out some of that a little bit more, because to me, they both still seem to have kind of like a volume centric outlook to them.
Yeah. And they, in the model, so in the second paper now, we're kind of transitioning to the conceptual model and detailed framework for stress-related, strain-related, and overuse athletic injury. On page 4 of the PDF, or page 729 in the top right, based on wherever journal this is coming out of, but Science and Medicine and Sport, it's figure 2 is essentially the encompassing model, but they still incorporate macro damage, single one-off, it seems to me, one-off injuries and then cyclic loading. So they differentiate between those things within this model. So you're trying to be all encompassing. So, Chris raises a good point with that question, is that we're looking at this overuse model, but it might just be a framework to start with for all stress strain related tissue injuries. Tony says he was surprised not to see Scott Dye's envelope of function and mentioned. So it's just funny because I'm just going to put this in there. I had this to share, but it's Scott Dye's 1996 original paper on the envelope of function. So I just put that in the chat, but only because Tony said that. I think that's probably going to be one of my practical takeaways, is like papers like this, again, are not meant to answer any particular questions right now. Essentially, it's here's a model, poke holes in it, and let's use it potentially as a framework for research to answer some questions. This is going to be a slow go, but one thing that I did have in here that was interesting thought is now thinking about how different tissues respond to load. So learning a little bit more about bone the last few years, reading a lot of Rich Willey's work or at least him distilling it down, and others in that field, and saying like, oh, okay, bone seems to respond favorably to high magnitude but low volume, but potentially high frequency as well. So you hit bone with these high impact forces, maybe 15 to 20 reps, and then it almost goes numb from a response standpoint. And so any stress beyond that, you're not getting necessarily as much of an adaptive response, but it comes back to life in short order, and then you could probably do it again. And then we've got muscle, that just the nature of the tissue is a lot more compliant, much different interplay of the Young's modulus, but essentially that's just the interplay of stress and strain of the tissue. And then you've got tendon, which we don't quite know, but Jill Cook on this recent casual chats that we had with the Sports Performance SIG said that she wouldn't be surprised if tendon responded very much like bone, in that high magnitude, high frequency, but lower volume doses of load would maybe be its love language. Whereas with muscle, it's kind of whatever property that you want out of it. But what's so hard though, is because when you're doing a jump or a sprint or high volume cyclical loading, it's not like you're differentiating and teasing these tissues out individually. You're loading all of them. So it's hard to, That's, I think, what makes it hard to manage.
Yeah, I mean, that was a big takeaway for me, is almost kind of like something, an area that I feel like I need to get more acclimated to, is kind of just some of the basics, basic science elements, getting a better understanding of some of that, because like you mentioned, that's going to highly influence your exercise prescription based off of some of the adaptations that you want to go after, right? So I think having a good understanding, like you mentioned, of, you know, at what point do you see some sort of like desensitization with bone tissue or something like that, because it's going to really influence, from like a programming perspective, how much you're putting into the person's, you know, whether they're talking about foot contacts or impacts or something like that. Because essentially, if you give too much, you're not going to get the adaptation, right? And then we're almost shifting more towards the overuse category of things. So that was a big takeaway for me, is this, I feel like I need to get much more familiar just with regard to some of the basic science elements, because I think it has a real impact from an exercise prescription standpoint.
Jason had thrown out a thought in the chat. He says potentially non-traumatic versus traumatic in that sense. Maybe changes the way that we at least think about it from a prior standpoint or a history taking standpoint. It's like, okay, well, that person took a helmet to his knee, whereas she was running a bunch of mileage and there was insidious onset, and, you know, or whatever the sport is, you know, she could be a sprinter or a jumper or something like that. Working with a pole vaulter who has like a hip stress reaction in her hip, and she's super explosive, and there wasn't one moment, but she's like, yeah, I was just doing a lot of sprints and a lot of jumps. And then that happened, you know? So yeah, maybe that's a distinction. Chris, were you going to say something?
Yeah, I was going to say, Kevin, off of what you were speaking to about exercise, I think for me, the whole concept of tissue adaptation, Quinn, and what you were saying as well, I love that about the bone and connective tissue, because I feel like this justifies exposure of any person to some stimulus, right? And it doesn't take a lot. And there's a law of diminished returns, right? Like, you're going to get a very sharp response early on, but that's going to plateau. And so even just 30 minutes of walking, especially if it's weight training for any individual, you're going to get a very good positive response. But just continuing to dump weight onto somebody is obviously not the route. And so I think this gets into the thought of, when we're talking about tissue adaptation, the load's got to be heavy. But if you do cluster sets, if you do smaller chunks and bites, you can maximize that kind of numbness, if you will, or load numbness and sensitivity, where, you know, maybe our thought process of rest and recovery will change, where we can figure out exactly how much dose it takes to get a good osteoblastic response. And then we're going to do that every single day. And that may be why BFR does what it does. I mean, again, you could extrapolate this really far outward, but I thought that was really cool to consider. Obviously, we know different tissues respond differently, but some of this is actually much lower than we thought. You don't need as much, and maybe more often early on is the way to go. And then to Sean's thought, like, I love that thought of, it's just pain, because, like, is it an under rest? Is it an over stress? I mean, you have no way of knowing. And that's part of what we do, right? Is to identify the provocative variable. And so putting a name to like a training error may be difficult, and may lead us down a wrong path, is my thought. So.
Am I going to get the same microdosing for the third week in a row? Because I feel like that's where we're headed. I think I will. I think I will. But Sean's point in the chat is interesting, because at no point, I don't think that second article even mentioned the term pain. I don't think either one of these articles had that term, had mentioned pain at all. So that's a whole different element here. That's a whole different wrinkle. And they talk about that in the model. They talk about that as part of the limitations. This is based on a mechanical model of stress and strain and kind of material science. And I don't think anybody here would argue that that is relevant to a tissue injury. But I think I maybe mentioned this before or last week, when somebody comes in with what we feel is some type of tendon pain or potentially tendinopathy or whatever you want to call it, they're not coming in because they want to increase Young's modulus or they want to increase stiffness. They're coming in because they're experiencing that pain. Same with bone stress. They don't know that underlying osteoblasts are getting overrun and they're not recovering. What they know is that they have some deep aches and they can't, weight that area the way all of a sudden the way that they could. So it almost seemed to me like that structural or the second paper was kind of, they probably maybe left that out purposely. I mean, what do you think about that, Chris? Because it just confounds things so much. It's almost like something to add later. Like, let's even talk about this from a biological, mechanical level first, and then try to bring in the complexity of the pain experience.
So when I asked Judd about that, because I thought the same thing, I'm like, hey, so you're saying the word injury in the title, but you're really not talking about pain. And he said, of course I'm not talking about pain, because then that like dumps just muddy water into muddy water. And it does it. And so I think to the point we made in the beginning is like, they're trying to provide foundational levels. And there's going to be another paper, it sounds like, coming out sooner, that's just going to stack almost like a pyramid of understanding this at a fundamental level. I've been really impressed by some of his responses. I mean, again, he's in biomechanics and this is his world, but I like that. I like the fact that they are adopting this gray model. And it's one of the first groups that I think are embracing that concept. Like, yeah, we know that there's 50 different contextual factors on top of our physiologic, our structural, and our force factors. Like, yeah, these are obvious. We're gonna at least identify them, but we're gonna start here at the foundation and then build our way out of it. Because ultimately, pain is, I mean, let's be honest. Over the last 5 or 10 years, unless you've been living under a rock, you've probably been exposed to some type of pain education. And for me, the first 5 years of that was did nothing but confuse me, to be honest. I'm like, I have no idea what or when or where or how. And so now I think we're finally getting to a point that people are starting to embrace it. And so asking him that, back to your original question, Quinn, that was his thought. It's like, we wanted to provide something foundational first and then start to build more on top of that. But I would argue that he probably doesn't know enough about pain science to really go that route appropriately, potentially.
See, I kind of like the fact that they didn't really talk about pain, because from like a management standpoint, like what am I in? Like, is my goal just to like take away your pain, or am I looking to make, tissue adaptations and promote physiological change? Because I feel like that's something like with the position that we're in that we probably have a little bit more control over, because I know how, dosage and things like that, loads that I can expose you to. So at least I know at that point that I'm trending in the right direction of getting like the biological and the tissue change that I want. But if we're talking about just dealing with pain, then what are we left with? I'm here, I'm just trying to make your pain go away. So I think, to me, I like the fact that they didn't even really mention it, because I think what they propose provides much more actionable things that I can implement, as opposed to just, I'm here trying to make you feel better or, eliminate your pain experience.
The pain is going to be a rate limiter, right? I mean, because how you're going to be able to get that person to express or to absorb certain forces that you're looking for within that. So there's always going to be that interplay in rehab with pain versus just what load effect that we're trying to do, or what dose effect we're trying to do to drive those physiologic changes. Because if I can't get you to weight shift over to your right doing a squat or something, I have to figure out how I'm going to go about loading those structures in a way that's going to create adaptation. And if I have to have a maximal load enough to create XYZ change in a bone or something, do we know where that load structure is or what that load tolerance is, right? Because what if they're osteopenic? What if they're osteoporotic? We don't know what the osteoblastic, osteoclastic activity in those individuals is going to be, right? And then when I'm trying to load pain on top of that, it does muddy the waters incredibly but pain is almost always going to be a limiter to what we're trying to get. That's why we have to work in certain ranges, or we have to figure out other things so we can still apply that stress load. I don't think pain has to be the goal by any means. It's hopefully something that, but we have to pay attention to it, because if it's too much, we're not going to get the loading effect, not getting to the point where we can get to that load effect. So we have to have kind of that balance within. I agree, in this paper, they're looking at purely mechanical effect, because the pain isn't going to change my mechanical effect other than my ability to get to the loads or the dosage that I'm looking for. But so that's why we've got to stay there, because those are the easier controllables when we're looking at it physiologically, right? I'm a biomedical engineer undergrad. This is where you want to live early, right? But we still have a pain influence that's going to change how much we can stress and strain some of this stuff.
So bone makes sense to me from an adaptation to potential benefit and function standpoint, because it makes sense that something that's designed to hold up and support you and mass, the thicker and the more robust that tissue is, the better. It makes sense from a muscle standpoint to say, if my goal is to produce force, a bigger muscle has potential for long-term strength adaptations, or just training that neuromuscular system to do that thing. Tendons still kind of confuse me though, because it seems like there's this just kind of overlying assumption that we just want to increase tendon stiffness. But that's not exactly true, because too much stiffness would yield a breakable material. Too much compliance, you wouldn't get that storage, energy storage and release. But in at least 2 heavy slow resistance papers that I've seen, stiffness actually decreased after the intervention. Pain decreased, functional outcome measure function increased, the tendon stiffness actually decreased. Now maybe that's measurement error, but I'm still not super clear on the actual connection between just a linear increase in stiffness of the tendon and then that being of benefit, just kind of as a blanket statement. Number one. And number two, the things that, like Chris, you were on the casual chats with Jill Cook. And to be honest, like she's like a Mount Rushmore of tendons for me. But I get confused sometimes when we like plyos. She says that plyos load the tendon the most, high amplitude, low duration. So short time epoch and super high force going through the tendon, but that's not what yields tendon adaptation. Plyos don't make your tendon any stiffer. So what are we doing when we're introducing plyos and people can do them better over time? You know, what are we doing with a graded exposure effect? Is it just, so these are just open-ended questions, but like the tendon adaptation piece still kind of confuses me a bit. It doesn't seem as linear.
Yeah, I always found that interesting in reading some of her papers, because and funny enough, Scott Morrison and I got in an argument about a month and a half ago where I said, well, no, Jill, he said, you know, heavy slow resistance for tendons is it is the end all be all, right? It is the thing you need to make and change the mechanical properties, AKA the stiffness. And you could argue how you measure it, and you could certainly argue where that stiffness is. That's probably a talk for a different day, and I said, yeah, I understand that. But Jill's also going to tell you that high velocity movement is also necessary for tendon stress. And he's like, yeah, but that's further down the chain. And I'm like, I know, but I'm telling you that she still believes in that. And sure enough, she comes on, and that's the paradox, is you do something heavy, slow resistance to make something more stiff so that it's more tolerant during a highly ballistic, plyometric, high velocity movement. And I'm like, in nowhere else, like following Wolff's law and like the said principle and all these other crazy acronyms that we have, in no other world would we say, yep, I want you to just do squats and that's going to make you tolerant to sprinting. Like that would not be okay, because you would need to do something relatively at higher velocities and build over time. But for some reason, the tendon is okay with that. I agree with you, Quinn. Like it's confusing to me, but I would still, I mean, again, based on what she said, I would still follow that pathway and say, and maybe it's because of pain. I don't know, but maybe that's why the stiffness went down, is because we implement some heavy slow resistance instead of high velocity. I find that's where I'm the most curious.
It could be the viscoelastic property of the tendon, where, you know, the heavy slow, where we're getting into more of the viscous component, and that causes some strain on the tendon. And there's some literature, I always mispronounce his name, but the Amarapatas, from like 2000 to 2010, doing all of the like high load isometrics and like looking at tendon stiffness. And they said, you know, strain the tendon about 4 to 6% seems to yield adaptation from an intervention standpoint over time. So maybe that's what does it. And a plyo is just not enough time to put that strain, and you're just working on the elastic component of the tendon. Honestly, I just don't think we understand it well enough to describe what the hell's happening. But clinically, I will load people slow and heavy. And if they're going to need some type of energy release, then we're going to be doing that too. And maybe I just don't see enough of them, but I feel like I see a lot of them where heavy slow gets them more tolerant to heavy slow, and might get them in the door for plyometrics a little bit more than had they not done that. But there is still an acclimation period to plyometrics from a tolerance standpoint. Like at some point, you got to just do those, and they're going to kind of feel sucky for a little bit, you know. And that's why I keep coming back to this microdosing concept, because I don't see a reason to wait. If you can kind of slow down the intensity and the rate, and I'm not really thinking of tendon adaptation, I'm thinking just tolerance at that point. I'm thinking whatever adaptation is going to occur due to the repeated exposures. What becomes relevant for me, though, is this idea of frequency, potentially volume with each dosage, and frequency if I kind of model it in my head like bone, as opposed to muscle, if I'm going for like hypertrophy or something like that.
See, I'm still confused with the tendons, because my understanding was with more like ballistic, highly elastic activities, there's an increase in like cross links within the tendon, and then with the heavy slow, there's a decrease. And to me, doesn't more cross links within the tendon make it stiffer? That's why I'm confused, because I've seen research from Keith Barr, and his whole thing is, you know, titrating, you know, ballistic activities, plyometrics, you see an increase in collagen cross links, but with the heavy slow is more for kind of tendon health, where you see a decrease through there. But it doesn't make sense to me, because if we're saying that heavy slow is increasing tendon stiffness, then what's happening with the ballistic activities?
Yeah, he says that slow, like a wall sit, like an isometric, but he basically describes it as that viscous property where you're actually going to decrease cross links. That's with an isometric. So to me, it seems like the complete opposite of what tendon literature is showing us, with like most studies showing an increase in stiffness are from isometric protocols. Tony brings up a good point here. He says, aren't there differing stiffness properties of different tendons? Yeah. So like patellar tendon versus Achilles. I'm pretty sure that from kind of a baseline standpoint, the Achilles, you're looking at more compliance versus stiffness. But you're right. So, but that's kind of my point, Tony, is like, if I feel like we're all just, we just want tendon stiffness, but maybe that's why the Achilles heavy slow resistance protocols don't seem to be as effective as the patellar. I don't know. Barry.
Oh, go ahead.
Sorry, Megan. What were you going to say?
Oh, I'm just going back to, were you going to go back to Barry's question?
Yeah, he said question. I was going to say you can unmute him, or he can unmute himself.
Hello, can you guys hear me?
Yes, sir.
Hey, how we doing? Yeah, so I'm gonna play devil's advocate for you guys right here. So hang on, because I'm gonna blow your minds here. So I'm hearing a lot of really interesting debate with everyone here. And I gotta tell you, from reading this article, I don't like it. I hate the article. I'm not gonna lie with you. Now, the reason why I hate it is not because of the structure or anything like that. I think it was well thought out. I think it was a good intention on this article. I really do. But everyone is bringing up phenomenal points. You know, we got the tendons over here. Paul did a great a great thing about bone, osteoblast, osteoclast. But realistically, as I hear you guys and think about this, I think we really are all talking about the same thing. But we're missing, I think, this point of overuse activity in athletes and how did it really occur? And that's why I was putting in the chat, I'm backing up that a good evaluation and good questions and just watching and looking at how the patient moves, I think that personally is better than, what if it's a tendon or a muscle or a ligament or a bone, just by, if somebody comes in and plays paddleball and they're hitting the paddleball and their shoulders killing them, let me see it. Let me see what we're working with here. And I think, again, this is me just personally, my opinion. I think that might be better than just kind of really getting down to the intricateness and just kind of looking at the foundation of what he's really working with. And that's just me.
No, I think that's a good point. I would also posit that this discussion and this paper aren't necessarily negating that, where we're going in pretty deep on some of this stuff, but at the end of the day, we're probably going to pull out of that rabbit hole and deal with what's in front of us as best we can. So I think your points are well stated. I think for models like this, if we're going to try to make sense of these things long term from a research standpoint, potentially answering some questions from a longitudinal standpoint, papers like this and models like this can be useful as a framework and a jumping off point. But you're right, on the day-to-day, the patient's history and our prior knowledge and our interpretation of whatever evidence that we have before us is gonna take precedent. I will say though that some of these injuries are hard to get and to reproduce in the clinic. So, for some runners or anybody else that they've experienced their thing at loads or volumes that you can't really reproduce in the clinic, sometimes it comes back to some of these things, where we're not going to see it in the office. We've got to kind of think about contextual factors and how some of their training, look at their training history, and maybe dose a program based on what we feel is going to, stress tissues in a specific way. But, these are all estimations. So if I'm doing plyos in the clinic and I say I'm doing this for tendon tolerance, and we do plyos, and then we go over to the leg extensions and I do isometrics, and I say I'm doing isometrics to increase tendon stiffness, that's just my mental model to help with some type of framework, just a place to start. And it's likely wrong, as all models are to some degree, but I think it can help just give people an anchor.
That was my thought as well, Quinn. Like reading the paper, and Barry, I agree with you. I mean, I think we're going to do some comprehensive, kind of eclectic 1,000-foot view of whatever the issue may have been. But yeah, Quinn, also, like, I feel like this gives us just more nuances and a little bit better understanding of if we feel like we can identify a specific tissue, like what's the best evidence-informed, evidence-based, qualifying manner to get there. And I think that as these things continue to emerge about bone tolerance and tendon tolerance and what gets us to that place faster without having to add extra, with that law of diminished returns. Like, I don't need to load them up any more than I need to, I guess is my point. Like, if bone is going to stop responding at a point and we can maybe 30 years down the road figure out where that magic point is, then I load you up to that magic point, and then we don't have to do any more after that. And so I think these models help present that, again, albeit certainly not so objective that I could take this to the clinic tomorrow and say, Quinn's got this issue, Kevin's got this issue, you need exactly this amount of dosage. I don't think we're anywhere near that. I think anybody would agree with that. But I do like that. I like the concept of saying there's a phenomena that tissue only likes so much, and may not need much more than that. If we do, then we're kind of playing with fire, is my thought.
Or just slow cook it, take whatever, if possible, whatever increase in load that you want to get to, if at all possible, logistically, from a competition schedule or whatever, if you can extend that time period, you get to the same point. But maybe that helps as well and more sustainable. So there's not that cliff that we fall off. I'll go back to the pole vaulter. I find this pattern to be pretty common, where she said, before I got hurt, or before, I got hurt, meaning before her hip got to the point where she couldn't even run anymore, training was phenomenal. I was more explosive. I was jumping higher. I was running faster than I've ever in my life. And I thought, well, how about more? Like, this is going so well, more, and sometimes it's not even that. It's just like, we're always teetering on this line of performance and recovery. So I think that frameworks like this can potentially help us. So this is going to be a slow go. We're going to be coming back to this paper in a decade. Go ahead, Kevin.
I mean, I agree. Like, I really like this paper because I think it does provide me a little bit more maybe guidance in terms of how am I going to actually intervene to address some of this. But I think the one thing that I was kind of thinking about it as I was going through this was, in many ways, we kind of have to have an established working and identified diagnosis to start to implement some of these things. And I think that's something that we kind of go back and forth with a lot in terms of being like, how important is the diagnosis? And I think if we're going to start to implement some of these loading protocols, utilizing some of the basic science aspects, trying to intervene to promote adaptations in tendon or bone, we kind of need to have an understanding of what is maybe the primary driver of some of the symptoms or the issues that they're having. And I think it's hard in the musculoskeletal world to kind of hone in on a specific diagnosis. So in many ways, while I think it provides a lot of evidence and value in ways that we can maybe start to address certain tissues, that's, again, it provides that we have an established and a correct working diagnosis to a degree, does it not?
Yeah. It's always going to go back to what our diagnoses specific enough and our interventions specific enough. But yeah, I think striving to understand the complexities of these complex systems, but also having a mental model to start from, to at least be able to gauge progress. So if you can at least start at a similar spot, employ your interventions, whatever what you think you're loading, the exercise progressions, but you're not getting the response that you want, at least you know what you did, and you can kind of go back to the drawing board and potentially head another direction. And I think for me, at least, that's where these things can help organize our thought processes. Barry's, he asked a good question. Why does it matter if it's bone, or muscle? Well, those tissues can respond differently. So I would check out the second paper, and they kind of go over that and some of what we mentioned in the beginning of this conversation, whereas it seems like bone adapts to high loading but lower volumes, where you can increase the frequency. But if you're wanting a muscle to grow, you're probably going to have to stack volume over time. Trying to get a bone to adapt versus a muscle to grow, the movements are probably going to be very different, and the dosages are probably going to be very different. Tendon is that thing that's kind of stuck in the middle that I'm still kind of confused about, as we had talked about before. Let's go to breakouts. So as always, Megan has created some amazing prompts that are just going to get your brain gains growing. What's the dosage for brain gains? Okay, so I always say this, if you're gonna leave, if you don't want to do the breakout rooms, that's totally fine. But go ahead and dip out now so that the rooms can be even. But we want you to stay. There's no pressure. We're all in here to learn. So don't be scared or nervous or whatever. Okay, I'm gonna put a prompt in the chat. I've got a few that I've saved, but This is a really good one. So we haven't even talked about this. Pulling load away and to the decrement of performance. So we'll start with those two, and I'll give you a couple more as you guys are going, but we'll go ahead and break out now. And we're off. We back.
We were in the zone, Quinn. It was in the zone.
Dude, I'm sorry. Well, what'd you guys talk about?
Meredith, you want to take that?
Oh gosh, put me on the spot. All right. It was the idea that we were talking more about how some people can have their issues with their pain is coming from their head rather from their body. But by finding that, oh gosh, words, this does not bode well. Being able to find those muscular imbalances and address them in that way creates a positive feedback loop that's going to allow your person to think that they're in less pain, regardless of whether or not that's where their pain originated from. And then it was further on to the idea that they don't necessarily need to be made stronger on a whole, as in lifting more weight, as creating that stability within their body to feel more comfortable in the things that they're doing. So it's not always about just strength, it's sometimes about protection.
So maybe kind of the idea of the process of training being kind of the special effect versus the end outcome.
Yeah, and that, I mean, I'm only a third year, so I don't understand everything equally well. But the idea of having to do the isometric exercises for tendons, it's about kind of resetting to me of the stretch shortening cycle in the Golgi tendons, where by stretching it, you're reminding them about the ability to contract, and that could help in that way when they actually go to do those plyo exercises.
What else? Anybody else? I'm sorry that I cut the room off. I never know. You know, I'm like paranoid. What if the conversations are not going well and everybody's like, "Oh my God!"
I
Like,
feel bad. That was all that was. I mean,
okay, well, it worked. Thanks, Chris. Kevin, what did you guys talk about?
Yeah, so we kind of talked about how everybody liked the framework, but we agreed that it was maybe a little bit difficult in terms of like a practicality aspect with regard to kind of in clinic, just because we are kind of dealing with humans. And like the point that you made earlier, you know, the person's not coming to me because they want to increase tendon stiffness. It's usually because they have a limitation in some sort of task or activity that's important to them, or they're dealing with some sort of pain experience. So overall, and maybe just lacked a little bit of clinical application. With regard to the second question, you know, I couldn't really think of a time for myself where I've done that outside of maybe something that was more like a post-operative condition where you kind of do have to purposely kind of stress shield from an area, whether it's a cuff or something like that, just because, you know, you've had a surgical repair, you got to allow time for kind of biological healing and things like that. So I guess that was kind of something that was more of a superimposed constraint, as opposed to I'm actively altering a plan of care to minimize the load tolerance of something. So that was a little bit more of a challenging one in terms of thinking of or recalling times where you purposely kind of offloaded. We had a couple ATCs in the group, and they mentioned where sometimes when you're dealing with an athlete, you may remove them from sort of play, which would kind of be seen as, I guess, trying to reduce the load tolerance purposefully to allow symptoms to calm down. And what we kind of talked about is it's really kind of challenging to find that balance in terms of you want this person to be, you know, pain-free at rest or something like that, but how long do you really keep them outside of their sport or their activity that may be an initial sort of trigger. So I think finding that balance was challenging. So there were some good insights from kind of the athletic training side of things in terms of, you know, when to push them back versus pull them away.
It's also hard. Like, I'm trying to remember a time that I pulled somebody back too much as well. And I think that it's hard for me to think of those times only because it's hard to know if that happened. Like the outcome is maybe they felt better, or maybe I just stopped working with them. you know, but I don't know long-term, you know, well, did you, like, you know, 2-year follow-up, well, what happened after we stopped working together? I can tell you that that people get flared up on my watch. I can tell you that happens. But it probably works the other way too. I've probably been overly conservative in the past and didn't properly prepare somebody. It's so hard to know, because it's like you said, if they pull back enough for the sensitivity to go down, but not so long or so much that you have a decrement, you know, you're finding that nice sweet spot, but it's hard to find that. And that's why I think we kind of gravitate towards, well, let's make a list of those most provocative movements. And if you literally can't do any of that thing, let's figure out how to get some mechanical tension on your body to, you know, the thought is, well, at least we can maintain what we have. But really what that means is we can slow the regression, because you're not going to maintain, you're going to get weaker because you're not training, but you're going to mitigate the loss and you're going to slow the regression so that when you can start to push again, you're in a better spot. You're not as detrained as you were before. And I think a lot of times that's the best we can do.
The example that Jordan just put in the chat was the one that was brought up in our room about sprinters and like hamstring strains, I think it was specifically.
Yeah, so Jordan says another common example that he's experienced or seen with sprinters or runners, the most immediate reaction is to have them stop running. Jordan, are you saying that's like incorrect, or say they get injured or they're hurting a little bit and it's like, well, you just shouldn't run or pick a new hobby? Or
I think the first initial thing that came to mind was specifically to like sprinters. And like, typically you're going to tell them to stop sprinting. Typically right. It could vary, but like in terms of percentage, but like generally, if I had to guess, most people would tell others to stop sprinting. And I can see definitely how that would deload them depending on whatever the time frame or the severity of the overuse or acute injury might be. I think it really varies depending on, the runner in this population specifically.
Sprinting's an interesting one because it's tough to prepare somebody for sprinting without sprinting. And like, also when you pull your hamstring sprinting, it's really hard to sprint. So it's like, okay, well, let's low hanging fruit. You can find, you know, all these loading strategies that are great, you know, bridge variations, Nordics, GHDs. You can add velocity to those, like a split stance RDL, where you go slow at first because rate's probably going to be somewhat of a trigger, but then you can have them go down purposely fast, and then they have to absorb that at the bottom and kind of spring out of it. There's lots of different strategies, but none of those put the velocity, that load with the velocity that actually sprinting does. And so, yeah, it's hard to grade that. So a lot of times what I'll do is we'll do like prowler sprints, pretty heavy. So it's not even really a sprint. It's probably not great long-term for their sprint mechanics, but it's a short-term strategy to get them moving fast again. But they can't, first of all, the prowler's in front of them, so they can't overstride because they would kick the thing. So they have to stay in kind of acceleration mode where they're pushing back instead of cycling. And it slows them down. So it's kind of like maybe an intermediate step there, but that's a tough one. Anybody else have thoughts on that?
Yeah, I think sprinting is really tough. Like, one thing that I guess I've kind of changed in terms of, like, I try to get people running as early and as often as I can. But the thing is, like, there's a huge difference between running at like 70 to 80%. And then once you cross like 85 to 90% of max velocity. And a lot of times what I've found is people will be cruising, you know, through the early part of rehab where, you know, we're manipulating things. They're back into like a 70, 75% run. But as soon as you kind of hit that threshold to where we're now working at 85+% of max velocity, that's when they'll start to feel the hamstring again. So yeah, it's a tough balance. I think you can manipulate things like, you know, uphill running or something like that, where you're kind of working on some of the front side mechanics, but it's very challenging once you kind of hit that 85% and above, because that's where you're going to get the most strain on the hamstring there. So usually what I try to do is I try to get them running as early and as often as I can up to about that threshold there. But then it's just going to be a time thing and exposure, because you're not going to really know until you start to hit those, max aerobic speeds or higher end velocities.
And if it's an actual sprinter, decent level sprinter, you can mess with mechanics too, because they might be able to conceptualize that, make sure they're not overreaching, make sure their ground contact is underneath their body instead of in front of their body during top max velocity. So they don't have that braking mechanism. But, if it's a field sport athlete or a recreational athlete, it's tough. It's already tough to change mechanics, or let alone have somebody think about it while they're sprinting. And a lot of those wall drills and different drills are awesome again, but they're just not going to provide that. It's tough. Chris, you have thoughts on that?
Yeah, I'm the same way, and it's predictable, right? But this also, if we bring this back to the paper, like would tissue, I mean, Kevin, what you were saying, would the tissue impact change, like the tissue proper? If you got a magic ultrasound and you looked at it and you found that it was more muscular proper versus truly more proximal, we'll say it's a proximal hamstring injury, right? And it was truly more the tendinous junction, as opposed to the muscular component. Would that change your progression, dosage, et cetera? I mean, I still think in both cases, if you run it, if they jog, they're gonna be fine, right? As long as the lever arm isn't too far away from the axis, it's fine, right? So 80, 70%, whatever, yeah, you're good. Especially if you run on a treadmill where you don't have to pull yourself up the road. You're literally just hopping. I mean, you can run even faster on a treadmill because there's no like, again, that reach and hook. But would that change your decision making, like to kind of bring that to the paper?
I mean, I feel like it probably would, right? Because it depending, if we're thinking more just kind of like muscular belly, biceps femoris or something like that, I feel like it would have to change. And this is where it's interesting too, when we start to talk about things like fascicle length too, and like how much of that plays a role. But to me, if I found, on ultrasound or something, depending on where we had the experience, the tissue insult or the injury, it would definitely change the progression in terms of speed or something like that, or speed of the progression, for sure, I would think.
Yeah, that's how I feel too. So I do think there are circumstances where it would help that decision, because we know tendon is a little bit slower to adapt. It's not as bloody. There's just not the same response, and that there may be a different medium that we would implement and employ, a strategy of load and progression. Sure, but to the point, like I agree. I think Jordan, what you said is like people want to tell them to stop running. But if it's a sprinting injury, you can run the next day. Most people with a proximal hamstring injury are fine, as long as you're not having them get to that stride length that's really antagonistic, in my thought.
Chris, would a treadmill, because of the point that you made about not having to pull as much, would a treadmill potentially be a strategy that you use to get somebody back to at least velocity specific?
So what I do actually with these is, so at first, yeah, I'll let them go jog. Obviously, they're typically okay. But as we start building up speeds, yeah, you can start to build up the velocity on the treadmill. And then I'll take the treadmill, I'll turn it off, and I'll unplug it from the wall. A lot of them will let the belt spin without the treadmill being on. And then you can work on distance, kind of hook and pull. You could do the same thing with like a slide board, like the, and just, hook a band around it where the band is in the sagittal plane in front of them where they're pulling back towards it. But I like the treadmill because it lets them like pull and dig, like, and so I use that treadmill for both of those things. But I know, Jason's over there saying like treadmill is not real running, and all that. But I do feel like, again, this is just manipulating mechanics, right? Like the treadmill is moving, so you're not pulling, you're kind of jump running, which is a weird concept, but I do find that to be more favorable in these cases.
Okay, so we got into hamstring rehab. Here, fun. Hey.
Kevin's happy.
Useful takeaways, especially when we're talking about trying to model complex systems. I think the only other point that I had here was like an education point I find myself having with patients when we're talking about all these things is, even in figure number 1 of the paper, that the circle figure with the layers, those are all moving targets. You know, all of those factors, those intrinsic factors, and even the envelope of function. Because I'll explain the envelope of function to people, and if you're not familiar with it, just Google envelope of function Scott Dye, and you'll see the images. It'll make intuitive sense. It's a very friendly model for patient education. Originally for patellofemoral pain, it's been extrapolated to pretty much us trying to distill what we're talking about tonight down to a conversation with the patient. But you know, the envelope of function, you have this delineation where you've surpassed your envelope of function, and now you're risking injury by doing too much too frequently, or doing low level stuff too frequently, or doing high impact stuff, you know, at all, and based on your capacity. And the envelope is essentially your capacity, but that's a moving target from day to day. And and it's based on how you just trained, and your sleep and your nutrition. And that's the conversation I have with people that were like, well, I didn't hurt myself training. I hurt myself, you know, like 2 days later getting out of bed, or bending over, or like moving really fast to like cross the street, but I had literally just run, you know, sprint repeats, and I was fine. So it's those things that are hard to wrap our minds around. But if we just think about the complexity of how all of these factors that we can't even name interact and moderate each other, at least we can explain it in terms like that, where it's normal for us not to necessarily be able to explain those scenarios other than they're moving targets, and we control what we control when we move forward. But I just had that as a point, because I find that it comes up quite often, you know, doing too much too soon, and all these things, surpassing recoverable volume, surpassing tissue tolerance, all makes sense. It's just that when you have those instances where that's not how it seemed to play out in the moment, it still is. It's just not necessarily, it was still happening that way. It's just in our minds, there's a disconnect because there was maybe a time lapse in our minds. And a lot of that could have just be like a memory thing. Some people just forget that they were actually having issues before they really started having the issues, and they only remember the recency. Any other thoughts or takeaways from anyone? All right. Well, that was a good one. Megan just threw in the survey form. So if you have feedback for us, that's always helpful. So every change that we always make to these meetings are based on the feedback that you give us. So open that link up and give us feedback, how we can make these better for you. We will be back on very soon. If you're in the Clinical Athlete Forum, throw a topic of your choice in the planning thread. I won again. In fact, both topics that made the finals this week were both of my topics. So if you want to challenge me for the throne, then get in that thread and post up some good ideas and papers. Yeah, exactly. Okay. Otherwise, everybody enjoy your Monday evening. Thanks again, and we will see you next time.